The following programme is going to be about diagnostic overshadowing. And diagnostic overshadowing is when the presence of one condition or one diagnosis interferes with the thought patterns of making another diagnosis, so that if you see a patient and you know that they have learning difficulties, learning disabilities, or they've got a mental illness, then you might be closed to other causes because you're only thinking of that person as having that condition. The factors that make errors in diagnosis more likely were summarised in a paper in 2008 which reviewed 21 studies. And that found that the causes were when the condition was atypical or presented atypically, when it wasn't very common, when there were comorbidities, and when actually the symptoms were rather generalised and non-specific. GPs make decisions in a consultation, usually based on a few early clues by which they generate a few hypotheses and then test out those hypotheses with following questions. And the pattern recognition that this brings helps with efficiency and with the ease of jumping in the right direction for the diagnosis. The disadvantage of this is that if you make the wrong assumption and the wrong direction and the pattern isn't actually accurate, for example, if the condition that is not very common, if it's an atypical presentation, then actually you can go down the wrong diagnosis and down the wrong path.
I need to see a doctor.
I'll see what we've got available. Is it urgent?
Yes, it's very urgent. I can hardly breathe. And I ache all over and I'm not feeling right. I'm scared. I'd like to see a doctor now, if you would be so kind.
Well, I'll see what I can do. What's the name?
Eileen Preston. I have been here before.
I know you have, Eileen, I know you have. Take a seat and I'll see what we can do.
Right.
In the situation that we've just seen, the best thing for the receptionist to have done would have been to have rung through to the GP to explain the situation and ask if the GP could see that patient as an emergency or as an urgent slot. When there's a high demand of work, when we're not in control of our work, then our decision making is less than optimal. And in this occasion, the GP might well have been irritable, wondered whether the patient that he was slotted in needed to be slotted in, and so his decision making is likely to be less than ideal.
Hi, I see we've got Eileen Preston in again. Yeah. No, okay, no, I'll see her. I'll squeeze her in between patients. This is the second time this month that she's been in it. Yeah, it never ceases to amaze me how someone can squeeze so much drama into their lives. But no, there we go. And I suppose actually I need to see her for her blood pressure, and she's supposed to have stopped smoking, so I need to check on that as well. Yeah, no, I'll see her between patients, so I'll come out now and get her. Thanks a lot. Eileen Preston, please. Hi, right, Eileen. What can we do for you?
Okay, well, I'm finding everything really, really difficult at the moment. I'm finding it hard to get on. I can't sleep, I can't think straight. And I think my husband's having a bloody affair. Git. And, well, I keep getting these stabbing pains in my chest, you know, they're really, really sore. And they keep coming and going, so I don't really know what's going on. And I can't get my breath. So I'm just at my wit's end.
When a very anxious patient enters the consulting room and starts to throw lots of information, some relevant and some not, at you, it is very easy for a doctor to become anxious themselves, to have some of that anxiety transmitted to the GP. In fact, very often the GP unintentionally starts talking faster and reacting in exactly the way that the patient is. And one of the communication skills is to be able to yourself take control of that, to match and mirror the patient both in non-verbal cues and also in slowing the pace down, slowing the speed, slowing the volume, slowing the tonality down, so that you can actually bring the patient down to a level where you can get the relevant information.
So I think we saw you about 2 weeks ago, Arnie,
Yes.
and I gave you some tablets for anxiety then. Have you been taking them?
Yes.
Yeah. And how have they been helping?
Well, it's not good, really. I mean, obviously, like I said, I think my husband's having an affair. And I think that started when his hours got cut at work. And I think he found it really, really difficult. He was very stressed out and probably drinking far too much. But, you know, and I'm running around trying to keep everything together. And, of course, that doesn't help. And, well, a friend of mine, recently, she just told me that she'd seen him in the pub with a woman flirting. And that night he didn't get in till about 1 o'clock in the morning. And, well, none of this helps my anxiety, you know. And... well, the doctor, these pains, I've never had pains like it before. Well, that's why I decided to come and see you.
Sure.
Oh, I'm worried about my mum as well. You know, she's in hospital, she's had a stroke, and just things getting on top of me.
No, you've obviously got a lot on at the moment, and I can see that. And it may well be that we need to do a little bit more than the tablets. So I was wondering if we arrange you to see our practice counsellor, how would that be?
Yeah, well, I suppose I could give it a go if I can fit it in with everything else that's going on. Yeah, I suppose. Will it actually help with the pains?
Yeah, I mean, I think the pains are due to the fact you are just getting quite anxious at the moment, and I think if we can just deal with that, that will help. Yeah.
Okay. Yeah.
So, if I go ahead and arrange that, would that be okay?
Okay. Well, I'll certainly try that.
Yeah. As I say, I think it'll help, and let me just. Well, what I will do is I'll drop a line to our counsellor, and she'll get in touch with you in the next week or two, and we'll take it from there.
Thank you.
That's no problem at all.
Thanks, Doctor.
Okay, well, let's go, and I'll come out with you and have a word at the reception.
Right.
Okay, thanks.
Thanks very much.
Okay, Elaine, so we'll see you in 2 weeks' time? Okay.
Yes, thank you,
Look
Doctor.
after yourself, okay.
Thank you.
It would be a good idea in this consultation for the doctor to take Eileen's blood pressure for a couple of reasons. It's always a good thing to do the routine checks in a spirit of genuineness when you want to find out the best for that patient. Also, particularly in certain groups of patients, they may not come very often, and often those patients you really do need to take each opportunity to do the routine measures. In this consultation, the doctor hasn't excluded other conditions that could have been possibly present, for example, hyperthyroidism or heart disease. This is probably because Eileen presented rather an incoherent set of symptoms, and also because of his knowledge of having treated her for a good period of time with anxiety. And so his pattern recognition has not served him well to get the right diagnosis in this case. We do have what's called confirmatory bias, which means we ask questions to confirm what we're already thinking. And in this case, that hasn't led to him thinking about other diagnoses such as hyperthyroidism or heart disease. If the GP feels that there are things that he's missed or could have done differently and is worried that he has missed something significant in this consultation, there are various things that can be done. One of the advantages of general practice is that we have our set registered patients that we know we're going to see again. So if he was already had arranged to see this patient in a very short time, then he might not need to do anything urgently other than make a note for himself to pick up on the things he thinks he might have missed. If he is not going to see this patient for a while, or if it's really urgent, then there are various options. If the patient might not have actually left the premises when he realises, he could actually probably still catch the patient whilst he might be making another appointment at the front desk. If the patient has left, then the options are to ring them at home if he is really concerned, or send a letter. Or if they're actually getting regular repeat prescriptions, leave a note on the prescription to come in and see that doctor again. In general practice, making sure that you're reflecting on your care is always a good thing, particularly if you've had a consultation that's gone rather difficultly for whatever reasons, or if you feel that you've missed something, then it is probably quite a good idea to, at the end of that consultation or that surgery, to think what could have been done differently. You might, if you have a practice meeting where you discuss difficult cases, want to bring the items of that case to the rest of the practice team to see how other members of your team might have dealt with that. And this is always good for reflecting on these difficult cases.
It's been interesting preparing for this programme. I've obviously been aware of diagnostic overshadowing, but I think in preparing for the programme it's helped me re-emphasise its importance. In fact, there was a case recently in my own surgery where the fact that it had been re-emphasised to me would prove very useful indeed. And this concerns a middle-aged lady with a range of complex health problems that I'd been looking after for quite some time. I knew her very well. And she presented one morning for a review of her diabetes and also a review of her depression and anxiety. And in addition to those problems, I also knew that she had a hiatus hernia. And throughout the consultation, she was rubbing her chest. And I was running late, as often happens, and it would have been very easy to ignore the rubbing of the chest. But I spoke to her about it, and she said that she thought it was just her indigestion playing up, although she'd never had it as severe as that before. And it was with a kind of mixed emotion that I said, well, we need to look into that further, and at the risk of delaying the morning surgery even further, we arranged for her to have an ECG done. And I'm very pleased that we did, because when it came back to me, it did show that actually she was having a heart attack, and we managed to get her rushed off to hospital straight away that morning. And looking back, I'm just so pleased that I didn't do the diagnostic overshadowing and forget all about the other symptoms she was presenting herself with. It would have been very easy to pass them off as a long-standing hiatus hernia, but fortunately we didn't. So it just served to emphasise to me the importance of diagnostic overshadowing as a concept.